Awesome. All right, guys. So my name is Michael Dudley. I'm with a company called In Good in Health. Today, we're going to be talking about the key to population health, identifying and intervening with rising risk patients. I will say, over COVID-19, I got sick of webinars. Anyone else got sick of webinars? So we're live here together, and so I'm going to hopefully have a very interactive conversation. In order to do that, though, it might be helpful for you guys to share with one another, share best practices, share what you guys are seeing, what kind of programs you have. First, before I get started, who here is in primary care? 1, 2, 3. Okay, that's cool.
I'm gonna leave it there for the next speaker too.
I'm a guy. I know a lot about population health and value-based care. That's really what we'll be talking about today. I will say, just as a disclaimer on who we are, we provide chronic disease management at scale for primary care practices and federally qualified health centers. The reason I mentioned that is, one, to just kind of establish this is all we do. Let's literally try to identify needs for patients and try to be able to intervene on those on a monthly basis, but then also add, where my bias is, and also let you know I'm not a lawyer. So if you want to move into value-based care, consult with your internal or external counsel, because I am not going to be liable for anything like that. As an agenda, we're going to talk about where healthcare is today. We'll be talking a little bit about population health and what needs to be done in order to be able to move into population health. We'll be talking about what CMS is doing to help incentivize or push us that direction. And then I want to give you 4 tangible steps, what you guys can start to do to be able to implement now in order to help you be successful in value-based care. All right, I won't try. This is kind of a little bit of the depressing part of the presentation, so I'm going to go over this pretty quickly. But the cost of healthcare continues to rise. This is not sustainable. No surprise here. They're estimating about 20% of our GDP will be the cost of healthcare, with about $5 trillion next year is what they're predicting. This is not sustainable. In fact, many people have coined as sick care instead of healthcare. And there's continuing costs to rise. This is where I'll have you guys be a little bit interactive. Where those costs coming from, 3 major ones I want to kind of talk about right now in the clinical care section of our conversation before we move into the rest of what goes into patients' health factors. First is diabetes. So when it comes to the total cost of that the $1 trillion there, $325 billion comes from diabetes. 34 million people have diabetes, which is about 10% of the population, with an additional nearly 3% of patients who have undiagnosed diabetes. What's interesting about this is 27% of those with diabetes are actually of Medicare age. A lot of times we think chronic illness, we think this is from these elderly patients who are kind of entering into end of life. Well, unfortunately, we're seeing diabetes impact children. We're seeing it be much more prevalent across the spectrum of the life cycle, which is alarming. With about 88 million having even pre-diabetes. So again, this is something even alluding to this morning, is that we had a sedentary life. We have sugar all around us. We have food. We don't have to farm. Like, things are very easy for us, and we have to have either self-control or find some way to be able to kind of make a lifestyle change when it gets out of hand. Diabetes patients averaging about $16,000 in medical expenses each year, with $9,600 attributed to diabetes, dollars-wise attributed to diabetes, and medical expenditures 2.3 times higher than someone without diabetes. So I'd love to hear from you guys when it comes to the diabetic programs you have at your either primary care practice or some of the ones in your community. I'd love to hear from you guys who here has a diabetic program at your health center or system. Jennifer, I know you said you don't mind me picking on you a little bit, but you talk a little bit about your.
Sure. So at Concord Hospital in New Hampshire, we have a lot of multidisciplinary, multi-specialty care to really participate in and speak about all 3 diagnoses, really. From a diabetic standpoint, we have a great primary care program. We have the endocrinology program, where patients tend to go next. They will then be tied into a diabetic educator as well. So consistency of those programs, how prevalent those are. And then we also have a podiatry program that we just acquired as well. It's also and then still just trying to keep that continuum of care shared EMR access, so folks can actually access the same information about these items. At least on top of, is your patient compliant? Are they not? Are we making headway with them? Other disciplines.
Good, thank you. Anyone else want to add to that? Any type of programs you have in place you feel like are best practices to help your diabetic patients?
I would say we have one in our system, but the wait time is incredibly
long. Yeah.
So the primary care providers end up managing it, and they use a lot of educational steps, and they just don't have the time to do that. So that's really just, it's not something that's working. It's
Healthcare is short-staffed across the board, and so it's keeping up supply versus demand. I'm curious, are you guys selecting those patients based on who has diabetes and anyone who has diabetes, or are the physicians kind of hand selecting those, or do you have a population health team kind of find those patients?
I'm on a very large system, so the referrals come from many different hospitals, but I don't know what they do. I'm sure they have some kind of selective criteria, but it's unfortunate for those that could still use, the high risk, I'm sure, go there, but there's so many others that aren't quite meet that criteria, but that could work for sure.
Well, at least you're offering it.
Yeah.
It's a great first step. Hopefully that continues to grow. Thanks for sharing. Next is hypertension. So out of those total costs, about $131 to $198 billion when it comes to annual costs for hypertension. But 116 million US adults have hypertension, which is nearly half the population. 92.1 million of those 160 million have uncontrolled hypertension. In fact, about 23 million of those patients really only can be recommended lifestyle changes, which is makes things very difficult when it comes to how we might want to help these patients much more than that. Individuals with hypertension are likely more to spend more than $2,000 additional in medical expenses every year. 1 in every 7 healthcare dollars are spent on heart disease. Does anybody have any heart health programs at your practice, at your health center that you'd like to share with the group? Now we'll move forward to COPD, which more than 12 million adults have. It's the third leading cause of 30-day readmissions, over $15 billion annually. It's the third leading cause of mortality in the United States. Moderate COPD can actually cause someone to live up to 6 years of their life in disability. The average COPD patient spend about $6,000 more per year than someone without. So I think you get the point here. These chronic illnesses are very, very severe. So that's half the battle. The other part is it's continuing to grow, not just with Medicare patients, with patients across the board. So they're estimating about 117 million adults have at least one chronic condition. But when you think about just Medicare, about 66% of Medicare beneficiaries have multiple chronic illnesses. In fact, American adults in total, 1 in 4 Americans have 2 or more chronic illnesses. Then on top of that, Medicare beneficiaries age into Medicare every single year. So they're estimating 1.5 million beneficiaries aging into Medicare from 2021 to 2029 every single year. And Americans will have 3 or more chronic illnesses, about 83 million by 2030, which is a 171% increase from 2015. They're saying about 80% of inpatient admissions are for chronic disease patients. And then on top of all of that, you have a physician shortage. See that in the black, physician shortage projected to grow 104,000 providers by 2030. I promise the presentation will take a positive spin. But the point is that chronic illness is getting worse, and the sick system the sick health or sick care that we have today is a broken system. Whether you're looking at the dollars or you're looking at the number of patients that continue to have these chronic illnesses. So healthcare costs today are not sustainable. Is value-based care the answer? I heard with the Allscripts presentation brought up value-based care. It comes up quite a lot. It's a hot topic. But does anyone really know what value-based care is? Is anyone a part of a value-based contract? Is anyone in an at-risk value-based care contract? Do you know much about it? Are you guys getting downside risk? Are you capitation?
I'm not sure all the details. We have we're in a
Like an ACO?
Yes.
Mm-hmm.
Medicare shared savings.
Good. Okay.
And so we've been in that for a few years, and we have some PPS hospitals and critical access hospitals. The critical access hospitals were taken out, just financially was not sustainable, just the way we're reimbursed. but we've been in it for a while. So pop health is a huge topic at our.
Good. Well, you're in the right place.
Yeah.
We're going to talk about some pop health today, specifically when we talk about value-based care. And there's some other groups, such as Stellar, RX Live, RX. Sorry about that. Some guys that are out there with the booth that can help you out too. But ultimately, you're right in the right place. So what's interesting is that mid-COVID-19, everyone was focused right before the Delta. Liz Fowler, the director of CMMI, comes out and says, I want to make clear that our commitment to value-based care has never been stronger. And there's a number of articles supporting that we are moving to value-based care. In fact, when you look back at the history of how far we've come, thinking back about PQRS back in 2006, does anyone remember that? Did anyone help their practice get through PQRS? What a shift, Tom. Do you remember what that was like? Well, it was a road that continues on. We're still only part of that road going forward. We've come a long way. We've seen meaningful use introduced, meaningful use stage 2, which is transformed into MIPS and MACRA, which essentially MIPS was created as an on-ramp to the advanced APM side of MACRA. Literally just created just to help groups move into value-based care or start to get familiar with it. So it's really, really important to understand that. But there's also a number of other mile markers on this timeline. For instance, in 2015, Medicare created a Z code. Is anyone documenting Z codes? Anyone know what a Z code is? So, I work with physicians every day, and ultimately they just want to do their SOAP note, give as much information as they possibly can to the other people that are going to be touching this patient, and then check off as minimal boxes as they possibly can, and in order to get paid and move on. Many people see the EMR as really just a billing tool because of that. But here's the thing: CMS introduced these Z codes essentially to be able to document social determinants of health. Z code, I think it's Z55 through 65. Really, each one is very important when it comes to how these patients and what's impacting their health. And we'll get to that in a second. But I want to kind of point that out there because it's been around now for 7 years, but no one knows what it is. So it's starting to be introduced now. We'll talk about it a little bit more later, but it's interesting on the timeline. It's actually been around much longer than even the MACRA. We saw obviously COVID-19 with the emergency going on there, and then we had a couple programs released. In fact, we'll actually talk about Aco Reach and what that model looks like here in a second. So to your point, I appreciate you sharing that about Medicare Shared Savings. This is one of the more popular value-based care programs. I kind of want to show you, I think most of you in the back might be able to see this, but essentially there are steps moving from what is fee-for-service and what is traditionally what we're in today in many cases for a lot of people. But then all the way up these stairs, all the way up to true capitation. What's interesting is on this matrix, you have payment for service or activity. And all the way on the right, manage a population. So what does this mean? And so as we're going to be going through this presentation, I really want everyone to think multiple steps ahead. Right now we're at fee for service, but what are the people who are doing capitation well? What are they doing? And how are they being able to reach their patients? So I kind of use this analogy. Imagine this is some steps in your house, but there's flooding. You have to get off that bottom step before you're underwater. So I kind of want to show this illustration just because this is happening. There will be I promise this is my last, kind of negative comment, but this is really, really important. There will be a tipping point. You want to maybe, you can move up the stairs quickly. You can move up the stairs very, very slowly. There are a lot of people that can help you move up the stairs quicker, but you do have to move up these stairs. Might happen in 5 years, might happen in 10 years, might happen in maybe 20. But ultimately, these are things you need to be able to keep track of. So that comment there at the bottom, manage a population, that's where we're going to turn the conversation positive, and we're going to focus the rest of the presentation on. In order to succeed in value-based care payment models, we need to understand what it means to manage a population. So what is population health? Just as a history, the term dates back to 2003. It talked a lot about outcomes. People said, this is too focused on outcomes. Dr. Peter Slavin, president of Mass Gen, said population health is a management approach to redesigning the care for a group of people with the aims of making their care better and more efficient. So I really want to spend some time here. This is really going to be a focal point of how we go forward into the presentation. What you see on the left is actually how our county health rankings model is designed. And so what they took was these outcomes that were described as population health, there in the green, and kind of separating it into length of life and quality of life. So quantity, quality, right? These are health outcomes. helping patients live better lives and longer lives. These are the outcomes. And then there are a number of health factors, and then there's policies and programs that can be put into place. That's why I was asking a lot of questions about what kind of programs you have, what kind of policies you have, because that will drive these health factors to hopefully lead to health outcomes. Now, these health factors, kind of want to walk through each one of these. What you'll notice the second one down is clinical care. This is only 20% of the health factors of any patient, meaning that if your physicians are doing everything right, they're documenting things well, they're perfect diagnosis, perfect ICD-10 code, perfect referral, doing everything they possibly can, they are only impacting that patient 20% of their health and how long they're going to live and how well they're going to live over that period of time. So we're going to talk a lot about the other 80%. So on the top, you see health behaviors. These are incorporated in a lot of what we're doing in the EMR. These are things like smoking cessation, diet, exercise, alcohol and drug use, sexual activity, and accounts for 30% of these health factors. And then social and economic factors, education, employment, income, family and social support, community safety. This is 40% of these health factors and probably the hardest to impact and really get a good pulse on. And then finally, the physical environment is 10%. This is air and water quality, housing, and transit. So we're going to get into a little bit of these. This is very complex. No one's really truly mastered it, but I think when we look at groups that are doing capitation well, they're not mastering this, but they are doing these very well. They're trying to be able to help these patients as best as possible. I kind of mentioned about the clinical care being 20% and the rest of it being 80%. We're going to focus here. I think when we look at each of these categories, and specifically in mind of groups that are in capitation, they're handling the physical environment by, if they have a number of patients that live in an apartment complex and they find out that there's mold there, they'll go in there, rip up the carpet, put in new AC units. They'll do whatever they can because they know that, and again, a lot of these groups that are doing capitation, they're making $800, $900, $1,000, maybe $1,200 per patient per month, no matter what happens to them. So if they're investing, a couple $1,000s to rip up carpet, they're going to see that be reimbursed by not having that patient get readmitted to the hospital, et cetera. So really, really important there. We think about health behaviors. To your point, having a diet and nutritionist or having these classes to be able to. We heard last time I was here, had somebody built a walking track right outside of their center to be able to help physical activity. There's a lot of things that they can do around health behaviors. And the hardest one is probably social and economic. There's a lot of things that we see the capitation groups doing. They might be hosting a job fair, might be helping people when it comes to their education and funds there. But it's much, much more difficult. So the goal is really to provide person-centered longitudinal care for everyone. So right now it's very focused on acute, episodic. You have broken your hip, you're going to the hospital. You get sick, you go to the hospital. Well, these are all things that are on this timeline of this patient. And unfortunately, by the time that they get to Medicare, it's really hard to be able to reverse these chronic illnesses, especially take diabetes, which we talked about. Only 27% of the people who have diabetes are at Medicare age. So what does longitudinal care mean? How do we focus on the person-centered, not just the issue? Well, CMS has actually taken this and ran with it. So I think when it comes to healthcare, we have to kind of follow the money to know how to prioritize things. But I think it's even more important to go to where the puck's going. Know where CMS is trying to get us to go, and instead of being kind of a lagging innovator, trying to understand where is CMS trying to focus our attention. Who knows about the Aco Reach Model? Anyone heard of it before? It replaces a program that was the global and professional direct contracting program that's been out for a couple of years. It was just sunsetted and replaced by, for one, it was kind of a silly name for the program. So they replaced it by something that makes a lot more sense for what they're trying to accomplish, which is realizing equity, access, and community health. So they're really, I can get into the details, but really they're focused on the underserved. And they're willing to invest in it. It's a program that'll start January 1st. The window to apply for it has already passed, so won't get into too much of that piece of it. But kind of some core pieces that I want to pull apart, because I think this is really telling us to what CMS believes groups should be focusing on. First is the benchmark. So ACOs who have beneficiaries in the top decile of the most needy patients and the most underserved actually get an additional $30 per beneficiary upward adjustment to their benchmark. But then also on the flip side, if they're serving beneficiaries in the bottom 5 deciles, they'll receive a $6 downward adjustment. Keep that in mind. And there's some things that change specifically with a risk score growth that's being capped, really to help kind of adjust for this fluctuation. The biggest piece here, though, is social determinants of health. ACOs are strongly encouraged to collect social determinants of health data from beneficiaries. Gathering this data is a critical step in closing the care gaps for the underserved population. And then finally, all ACOs must develop a health equity plan and report progress and outcomes to the CMS Innovation Center. Does anybody have a health equity plan that you know of? That's unfortunate. I'm really glad that I'm kind of working with people that aren't as familiar with this, because I can kind of stay pretty high level. But it's really interesting to hear some of the groups that are advanced what they're doing. And every day I'm learning a lot. I was at NACOS last week and learned a lot from those ACOs and hearing what they're doing. But I want to kind of stay on that high level. You know, what can you guys do now to prepare for these bunch of stuff I know you hadn't heard of prior to today? First one I would highly recommend would be understanding your patient population. So I think most people know within maybe 5 degrees what percentage of their patients are diabetic versus hypertension versus have COPD. But I think it's also it's helpful to understand where do those benchmarks compare to the nation. So maybe if you have 40% diabetics in your community, maybe you should have a diabetic program. And that hopefully will allow you, by comparing it to the nation, understand where you should prioritize what type of programs to put in place. Because you can't put every program in place for your community. You have to kind of pick and choose. And so this might help you prioritize. But if you don't know within 5% kind of where your demographics are, what percent may have maybe are alcoholic, or maybe what percentage of your patients have graduated college, what percentage of them are unemployed. These are all social determinants of health that it would help if you knew. And right now, I don't think anyone really knows. They've mentioned specifically with the Z code, only 1% of physicians have actually submitted as a Z code before. But again, it's up on the rise. And whether you're reporting a Z code or you're just documenting it somewhere, incorporating it to some extent is really, really helpful. But it's understanding your patient population on the clinical side as well as the non-clinical side. Assigning patient risk. This is going to be the first thing that any ACO is going to make you do. The American Academy of Family Physicians has really 2 different options, or recommends 2 different options. One being kind of a 3-point scale: low risk, moderate risk, high risk, or a 6-point scale. And so when we talk to these capitated groups, they do a lot of outreach based on what strat they're in. So, risk strat 6, they're reaching out to that patient every single day. Risk strat 5, they're reaching out every other day. Risk strat 4, they're reaching out once a week. Risk strat 3, they're reaching out every other week. And then level 2 and 1, they're reaching out once a month. So these are things that capitated groups are doing really well. Who here is risk stratifying their patients either manually or using a population health tool to do that? Would you like to share anything about that?
I'm on the billing side, so unfortunately I can't share, but yes,
Yeah.
we do have a population health.
Okay.
Because we have started to open in the county-based care now, so we have we've left a fee for service for one of our, so I work for Partners Point.
Okay.
So we have a health plan, and we are now capitated with that for coping in that area.
Okay.
And then we also just signed up for primary care.
Ooh.
So, and we just started that. So we're starting to get in there, but I'm on the opposite side of it. So yes, we do have a population health.
I love it. So are you seeing anything else happen in these first 4 months of 5 months now of doing that?
Not so much yet, because there's still that mix, right? Because it's still, we're primary care with some specialty, but it's only our attributed patients. And so it's kind of getting through that piece of it first, and seeing some of the pieces that we need to start putting in. So that will benefit afterwards.
Awesome. Thank you for sharing that. I appreciate that. Yep.
We have a care management tool that identifies patients who are high risk based on admissions.
Mm-hmm.
We do a lot of HCC work with our providers and making sure diagnoses are accurate, and getting a risk score for each patient. I would say one of the barriers is like, it's like only attributed patients who are in that value-based contract. And so that's always been difficult to like to treat these patients one way, treat these patients a different way. So that's always been difficult for us and for care management because they only care manage a certain population based on the payer. But we do have those tools built in our EMR.
Good. Appreciate you sharing that. Thank you. Anyone else? So I think a lot of groups know maybe who their high-risk patients are. They're the patients that are going to the hospital all the time, and you're following up. Did you get home safely, and really kind of going the extra mile there. But if you had to look at the remaining, let's say this high risk is like the top 5% of most chronically ill, and you were to look at the other 95, could you just from looking at their chart, could you tell which ones are moderate risk, which ones are low risk? And I think that would be, if you were to look at 10 people standing up, could you name the 4 and 5 the other patients and which categories they would be in? That's really kind of a takeaway here is really understanding where your moderate risk patients are. A lot of the groups that we're working with when it comes to ACOs, they're really focusing on rising risk, and this is a key for them. They'll call them actionable patients or patients that you can move the needle with. This is really, really important. This is actually where the bulk of a lot of the spending comes from. So when we look at the most, as you probably expected, patients who are the highest acuity, they're going to be the highest spending, no doubt about that. But their chronic illness or whatever the reason that they're part of that acuity has gotten to a point where they're just trying to manage it versus trying to be preventive. So a lot of ACOs are really focused in on this rising risk patient, the bar that you see kind of in this fuchsia cranberry color. They're really focused on these patients because they know that if they can intervene now, they'll catch that risk on the longitudinal scale that we're talking about here. And then also when it comes to the dollars, there's a lot more because of how many patients are there and how willing and able they're able to impact these lives. There's actually 1.7 x more savings there than traditionally through the rest of the patient funnel. So step 3 would be benchmark and compare. So we kind of, when I mentioned MIPS and MACRA, I saw a lot of cringing. I saw a lot of people react. But as we talked about, MIPS is just an on-ramp to alternative payment models, advanced alternative payment models. But if you look at your decile 7, which is kind of right there above receiving a penalty, kind of look at these marks. So, screening for future fall risk, 78%, colorectal cancer screening, 58%, breast cancer screening, 70%, et cetera. These are, in the MIPS world, not bad. But here's the thing is that when it comes to being a part of an ACO, they demand more. And so, they're usually 6, 7, 8% higher when it comes to these numbers and these benchmarks. So it's important to understand where you are, though, compared to your peers when it comes to the primary care practices, but it's also important to understand how you compare if you were to be in an ACO. Step 4, provide person-centered care delivery. We kind of talked about this as we made this intro. There's 2 different programs that I'm going to talk about today. Both of these are essentially value-based care programs that are today currently being reimbursed on a fee-for-service basis. I'll kind of talk about the end. If you were to do the same program, but do it in some type of capitation program or do it in some type of downside risk, you would actually earn more money for doing the same thing without sending out those claims. First one being annual wellness visit. I know what you're going to first say. Our docs hate it. They want to touch and feel. This takes too much time. There's a lot going on, but it is a very helpful and includes everything we've talked about up until this point. Talking about social determinants of health, talking about a lot of these health factors. Can be covered every 12 months. There's no copay or co-insurance for the patient. And on average, you're receiving about $160 per patient for every encounter, which again, can only be once a year. And then you have chronic care management, which Medicare patients with 2 or more chronic illnesses can be outreached to and spent 20 minutes helping them manage their chronic illness. And the reimbursement actually went up 50% in January. So prior to January, New Hampshire was $41.76. Vermont was $40. Southern Maine was $40 as well. The rest of Maine was about $38. Boston was $45, and the rest of Massachusetts $42. And these all got bumped up into the mid-60s range in January. So it's really important. What's funny is that literally the entire rest of the fee schedule was reduced However, chronic care management, the reimbursement was increased. And that's because CMS truly believes that this can help patients stay out of the hospital. Let's first talk about annual wellness opportunities. So if you actually look, I'm not going to give you any templates or talk to you about how you should be doing your annual wellness visit. But when you just look at what CMS recommends is covered over this annual wellness visit, you start to see everything we've talked about so far when it comes to social determinants of health, et cetera. So providing a health risk assessment, health status, injury risk, behavior risk, urgent health needs, reviewing functional ability, level of safety, hearing impairment, a risk of falling, accessibility to perform activities of daily living, bathing, dressing, etc., etc. Provide health advice and referrals to health education and preventative counseling services, aimed to reducing identified risk factors and promoting wellness. Sound familiar? Health education, preventative counseling may relate to weight loss, physical activity, smoking cessation, fall prevention, nutrition, and more. Right? That's exactly what we've been talking about. So I know that annual wellness visits are very, very difficult for the physician to do. They don't like doing it. We even, last time we did this presentation, someone mentioned, they come in for the annual wellness visit, they find out that they have back pain. And then they come in for that appointment, and now they have this huge copay for a back pain appointment. And there are some issues with the program, but I'd love to hear from you guys. Who here is providing annual wellness visits regularly for your patients? Raise your hand. I'd love to hear some of the best practices, how you guys get around that, how you encourage the physicians to provide that. Love to hear from you guys. Just the pre-work or the whole way through?
The provider comes in at the end, but it's really all like execution and gaps in care, and so the nurse can do the majority of the visit. Also, pharmacists can do the visit. So we've just done it that way.
Thank you for sharing. Yeah.
We have a couple, so mostly
You guys can come in. We have some seats right here too.
the MA and the RNs do a lot of it, because it is that questionnaires. We also started to pilot more recently from a time perspective, just with shortage in our MAs. And there's the form, and as the patient's sitting there, they can fill out the questionnaires for like the health risk assessment and such, and then the provider and or the MA can review that with them in the visit. But that's already kind of filled out at least ahead of time.
Mm-hmm.
It seems to be working well just because of the shortage. Our MAs for the patients and ask those questions. It's more of a review of that instead.
Have you guys found a benefit? Do you feel like it does what it's intended to do and really kind of identifying some of these needs?
Yeah, it's definitely still, again, the annual wellness is really a question. It's really just a lot of questionnaires. And so it has definitely saved time for the providers. It does give some of the providers those opportunities where you do have some of those patients that will discuss their back issues. So now the provider, instead of setting up a separate visit, it doesn't get rid of obviously office visit additional, but it allows that patient to just have that conversation at that time.
Yeah, good point.
The Advantage plan is actually kind of better when you have a patient who has a Medicare Advantage plan, because they can have a visit and a physical, and they pay for it, so that Medicare doesn't do a good job of educating their beneficiaries on what a wellness visit is. They still think of it as a physical, and when you don't touch them, they get very upset.
Yeah.
So the Advantage plans.
You want a goodie bag, right?
Yeah. The Advantage plans, you can bill actually like 2 visits, and patients are much more happy, and they do a great job of educating their patients on what they can and cannot have. But it's a great visit because with those chronic conditions, you never see them for wellness. You always see them for their diabetes or hypertension. So it's like the one time you can talk about mammograms and colonoscopies and AAA screenings and all those things, because you sometimes forget. You think you do it because you see them so often.
Yeah.
But it doesn't actually ever get discussed.
Really good points. Yeah. Thank you for sharing that. Yeah, and then the second would be chronic care management. Is anyone providing chronic care management, the 99490 code? You are? I'll get through this, and I'd love to hear how your program looks today. But CMS has discussed how it reduces readmissions, estimating that a high-functioning program will cut readmissions by 23%. You'll get improved patient outcomes, and better improved outcomes when it comes to HEDIS, MIPS for those federally qualified health centers, UDS data. Physicians actually able to see complex patients, leveling the top of their license, meaning that when a patient's coming in, the physician knows, hey, they need to see me. They're not coming in for this and oh by the way this and oh by the way that. They know that they're there to see a complex patient, and their burnout goes down as well. Improved patient satisfaction, so patient surveys, CAP scores, etc. Patients are more loyal and willing to remain in the practice. So this makes patients more sticky. We're seeing Oak Street, we're seeing all these competitors come in that are offering a lot of these benefits to these patients. So having them be loyal and sticky with your practice is going to be really helpful. And then also reduces reactionary inbound calls. So these high maintenance patients that are calling in, it's kind of the 80-20 rule. You probably have 20% of your patients making 80% of the calls into your practice. Hopefully this can be reduced because they have someone that they can answer all those questions at any time, and hopefully reduce them because they're up front. I do want to talk about, because I'm describing this program in hopes that you guys would provide it yourselves. It is something that we do, but I want to empower you guys. If you guys want to go out there and do this program yourself, I want to let you know about two obstacles that you'll see. First is a copay. This could be arguably the biggest obstacle, unless they are dual enrolled. So if you guys were to roll out a program like this, I would focus in on the patients who have Medicare and Medicaid, or Medicare and also a payer who is willing to reimburse for it, because they won't have that copay. That is the largest obstacle we see. And then you see a lot of patients that don't believe they need the help. And really, this one's a lot more unique. You have patients, really, when we're talking about all those chronic illnesses, it's patients who know that they should be doing something. Like, hey, I'll never be a 110. So I don't really care if I'm a 150 or 200. Why not 300? So they just don't take it as serious. Or they say they might having maybe a heart murmur or something. So I've had these before. It's not that big of a deal. I don't want to bother anyone. I don't want to call an ambulance. But in reality, by having a care navigator, you can get involved with them. The downside to that is getting them enrolled, getting them on that type of person. Yeah, we all know these type of Medicare patients, a little more stubborn, a little harder to get that buy-in. Being able to get them and help them understand that they need the program is very difficult too. So best practices, if you want to be able to put together your own chronic care management program yourself, I would recommend this being a full-time role. If it is part-time, it will be inconsistent or ineffective. I can't tell you how many groups we've talked to that have rolled out a program, but then they just kind of call 40 patients over here and then 40 patients over here, and then really you're not getting any consistency. You're just kind of getting a random call. And so I think really when it comes down to helping patients make lifestyle changes, it does come down to consistency. Knowing somebody's going to be calling you and asking for your blood pressure, you're like, all right, I need to get my stuff in order. I need to know when Sally's calling me, I'm going to have this ready to go. And sometimes, it motivates them to say, I told her I would, cut out soda. I told her I would do this. And so they get excited, and it's all about consistency. If you don't have that, it's really difficult to do. And if it's part-time, it ends up becoming less than part-time because you're short-staffed. It's really hard to be able to dedicate that time. It kind of leads into the second best practice, which might help for them to be physically removed from the practice, because how many times fire needs to be put out and someone's calling outbound patients. You're like, that's a nice to have. This is a need. Come in here, help us out, help us put out this fire. And so from that perspective, it would help. Now, there are some people that believe it is helpful to have them in the practice so they can see the patient face-to-face and build that patient bond more intently. But I do think that they're going to be pulled in. It's going to probably cause more harm than good. You should track trends and insights to be able to measure how well you're doing. If you're just having people call people, that's great. But understanding what kind of trends you're seeing. Are we actually whether it's even, it might be as simple as in the EMR, just putting down the blood pressure reading or putting down some of this information that's a little bit more discreet. And then finally, this is a program meant to keep patients out of the hospital instead of following up with a patient that left the hospital. That is a great program. It's more transitional care, helping the patient move back into that lifestyle that they had before, but it's not chronic care management. Chronic care management is really helping the patient provide preventative care to keep them out of the hospital. All right, because this is what we do, I thought it might be helpful to kind of give you guys some of our data collected from last year. So we provide outsourced chronic care management services the people, the technology. We have artificial intelligence. I'm not going to bore you with all that because I don't want this to be about us. I want this to be about the patient. So I'm going to talk about the interventions. These are ways that we are intervening with your patient. If you can do it through chronic care management, that's great. If you can do it some other way, that's really the intent of this slide. So this data was collected from about 9,000 encounters over 4 different geographically different clients, just to kind of give you some percentages of what these interventions look like in 2021. So appointments, about 2,000 appointments were created from these 9,000 encounters, about 7,000 opportunities for education with the patient, and then medication interventions are about 6,000. And the rest are much, much less. So I'm going to kind of talk with you about the top 5 interventions that they've done. So top 5 interventions last year, COVID was your number 1 answer, surprise. But I think there was a lot of misinformation. So you have a care navigator who's able to explain the risks of this versus the risks of this, and really kind of make that clear so the patient can make that decision is really, really important. Diet was 15%. So it's, explaining, physician says to the patient, you should have a low sodium diet. They take the salt shaker off the table. They think they're compliant. Meanwhile, they're eating Chinese food. They're eating frozen food. You know the deal. They just don't understand what exactly that means. So providing a lot of educational interventions. Hydration's a big one, 11%. Activity, exercise. And so this is really from a care navigator. You can call them care coordinator, whatever the name you guys want to call them. But really, their goal is to try to also understand what are the goals of the patient. Do they have a milestone? Do they have a graduation of a grandson coming up? Do they have a wedding of somebody coming up? What motivates them? And then connecting that with the clinical care to be able to help these patients make lifestyle changes. As you know, Medicare age patients, it's hard to get them to make lifestyle changes. So they have to be motivated in a way that's unique to them. You can't just say your doctor said this, so you should do it. So these are really, really helpful when it comes to activity and exercise specifically. And then scheduling some educational appointments. Hey, there's a lot that we need to cover around diabetes. Why don't you come in and have that diabetic appointment? One, before entering this industry, I was really surprised about was medications. How many patients they just, their medication runs up. They say, hey, I have my appointment next month with my doctor. I'll just go then and get a refill then. Or maybe they just can't afford their medication, so they stop taking it. Or maybe the statin makes their stomach feel upset, so they just stop taking that. Or they're cutting pills because they're coming close to there's all kinds of different ways that they're not being compliant. In this case, it's really hard to read, but nearly 65% of the interventions that we're doing with medication are around compliance. Refill request, obviously confirming the supply, access and pickup, and office coordination round out that top 5. And then finally, appointments. You obviously have your, hey, you really need to see your physician about this. It's more than, just a skin tag or something. It's like, no, you need to go see, this is not normal. We need to come and have you see the physician. So they actually escalate those type of visits, which increase the revenue. And then you also have referrals to a specialist, about 17%. And then I think the most important that we've talked about today is quality appointments. So 11% of the time, they're able to either schedule annual wellness visit, mammogram, some other type of quality appointment that is needed for that patient. Lab work, behavioral health kind of rounds out that top 5. I'll get into some of this, but I think just based on time, we'll kind of skim through it. But essentially, here takes a case study of 10,000 enrolled patients under management. And there might be 2,800 fall risk patients if 97% of them had an assessment performed. Again, this is not necessarily our data, but the data from this case study. 385 associated interventions were provided, which is about 14%. And then of those, 38 falls were avoided. Now, 38 falls may not seem like a lot when you're talking about 10,000 patients, but every hip fracture that comes from a fall being avoided costs $37,000. So if you are actually stopping 38 of these, that's a lot. If you look at that over the total population, that's $6 per beneficiary. Well, that's just one risk. What about another risk? And so all these risks combined, $6, etc., will add up at the end of the day. And that's really why value-based care and working on a downside risk is really going to be beneficial. So here's an example of what, say, if you did chronic care management. Let's just say you did it yourself, and you just did it fee for service, meaning you sent out that claim for the $65 per patient per month. Just by doing that service alone to 500 patients, and 500 Medicare patients were in your panel, you earn an additional $100,000. Now, let's say you did not submit that claim at all, but you're in downside risk. When you look at the total panel expenses, the cost of primary care services, the total medical reduction, and the new baseline, you actually would make an additional $20,000 from not submitting any claims. But this is just the cost of keeping this patient out of the hospital and reducing their total costs. I'd be happy to talk about this math later, but it's much more nerdy than you probably want today. Some other opportunities. So that concludes really the steps that I've wanted to talk about with you today. Here's some other opportunities, and I'd also love to hear from you guys to be able to add on some as well. Patient-centered medical home. Anyone currently PCMH? So has that helped you guys out? I hear mixed reviews. What's that process been like? It's just a stamp of approval, and
Yeah, I mean, the issues like that, I think we try to be patient-centered regardless of the status. So it's kind of sometimes feels just like additional reporting to another body. But I just don't know what the
are the morning huddles, afternoon huddles, things like that helping the clinical piece?
I think it initiated a culture change, but I think the culture's there now, and so I don't necessarily know that we need to like report our data because I think the culture has changed.
Yeah.
It's just, but I think they're probably at one before my time, but needed something to say you got to change the way that you practice. And now it's just so ingrained in what we do that I don't necessarily think that the stamp of approval is what is keeping us being patient-centered.
Well, that's really helpful. Thank you. No, it was perfectly well described there. I appreciate that. Anyone do any principal care management? So this is where you're really focused on a specific specialty. So, cardiology is a good example where you have, patients who need to be, have basically chronic care management, but about their specific cardiac issues, and it specifically kind of falls under that bracket. There's also transitional care management. So where you might have somebody come out to see the patient there at their home and really help make sure they make that transition from the hospital to the home better. You're shaking your head. Are you guys doing that? Do you mind explaining? You guys have nurses going out. Do you mind describing the program a little bit?
We do the calls. We have our pop health section, so they'll do the calls to initiate and then set the appointments based on the moderate risk and the timing. Billing for that, being primary care.
Yeah. Awesome. Good. Yeah. One program I heard from NACOS was the Familiar Faces program. This is actually where they had a primary care physician at the hospital. So anytime someone was admitted to the hospital, they were at that point introduced to their PCP. And it was one way to kind of, not everyone has a PCP. So, hey, when you're in the hospital, you're introduced to somebody and you get started down that road, which I thought was a good program to mention. Kind of similar with the geriatric emergency departments as well. What I wanted to talk about is, especially if we have any pediatricians in the room, but ACEs. Has anyone heard of ACEs before? Caitlin, would you be willing to describe ACEs and then PCE that you were referring to?
Or health outcomes later in life. But what newer research is finding is that positive child events, community activity, offset some of the negatives, and so there's movement going on to these negatives. Or if there's another programs.
Thank you. Appreciate that. And another program I heard through Alliday was just the Healthy Holidays, just sending out a postcard, letting the patients know their holiday schedule coming up. And if, hey, we got these are the days that we're closed, go ahead and schedule that now. And then that might be, who knows, maybe put up with a bunch of other pictures on the refrigerator or whatever. And maybe it's just a little bit more top of mind, but it's just really kind of inserting primary care where it may not be and trying to help these patients make some psychological different changes. But really, that's the majority of what I wanted to talk about. Any other programs you'd like to add to that list? Anything you feel like is identifying or intervening with social determinants of health or really helping all the health factors that we talked about? If not, I'll summarize things with the cost of sick care is unsustainable. Value-based care shifts the risk from the government to commercial payers or to the physicians with the responsibility of patient risk, imperative for physician groups and health systems to truly manage all the factors of their population and find as many ways to identify and intervene on that risk as early as possible. And I talk specifically about annual wellness visits and chronic care management. If you have any questions, here's my email. I will say if you connect with me on LinkedIn, nearly every week I try to share a successful patient story. For me, it's described. I kind of do it the same exact way. Sorry if, Jennifer, I've been bombarding your feed here lately. But it's I typically just mention, a situation where a patient had a need. One example was, a patient was a no-show for their appointment. So chronic care management, care navigator reached out to them and found out that they were just really lonely because their grandmother and their husband had died in like the last year, and so they were really having a hard time feeling motivated for their health because they felt really lonely. So they coordinated to set up with a dog adoption, and they were able to adopt the dog, with them. And now she's taking the dog for walks every day, and she's now found an invigoration with her health. Another story in South Carolina where a patient literally was, I think, 2 days after not having food, and they also had some dogs, and care navigator said, let me find a way to be able to, I think their car broke down, so they weren't able to get to the food shelter. So they actually found a food bank that was willing to deliver. They delivered that, and then they actually coordinated with the animal rescue and had them drop off dog food for their dogs as well. So it's things like this. I like sharing those stories. I think that we need more positivity like that in today's world. So that's all I have. Any questions for me? If not, you can connect with me on LinkedIn, Michael Dudley, and you can see these patient success stories. But we do have a booth here, and would love to have further conversations. But thank you guys all for participating. Everyone who jumped in and added their programs, really appreciate that. Thank you.